make things interesting. Thanks, Brad, for that excellent review. And it's a great segue into our next talk, which is being given by Dr. Manali Kamdar, who has been here since 2014, right, Manali, after your time at Stanford. And both Brad and Manali have really done a phenomenal job of building up one of the best clinical lymphoma programs in the country, and the work they've done with clinical research in this area has been just phenomenal. With that, Manali is going to give us a second update on lymphomas.
So good morning, everyone. Thank you so much for making it here despite this lovely weather outside. And I'm going to pick up from where Brad left today, which is I'm going to cover the portion around B-cell lymphomas. So there's, of course, a lot of updates, abstracts, and to pick and cherry pick through these thousands was a challenge, but I'm hoping to get an update back to you, which may be of clinical practice in terms of its relevance. So these are my disclosures. And these are the 5 subtypes of lymphomas that I intend to cover today. So as we all know, bispecific T-cell engagers have now been approved in relapsed refractory large B-cell lymphomas after failure of 2 or more lines of treatment. The way or the mechanism of action is that it basically is an antibody with 2 prongs. One sits on the CD20 B cell, and then the other redirects endogenous T cell and causes endogenous T cell kill of the tumor cell. And clearly, at this point in time, we have the ability to give 2 FDA-approved bispecific antibodies, one of which is glofitamab, the other one is epcoritamab. They're slightly different in terms of how they are given. Glofitamab is IV infusion, and it's time limited. It's only given for 12 cycles. Epcoritamab is subcutaneous, and it's given as indefinite treatment. So this is a broad overview in terms of cross-comparison across the 2 pivotal studies, both of which surprisingly have very similar results. And it's really meant to follow through each of these in terms of its outcomes. And I will say a total of 150 oddish patients were enrolled on both of these studies. The median age was about 60, with 3 as median prior lines of treatment. Both of these studies enrolled about a third of patients who had prior CAR T-cell therapy. The median time to response is about 1.5 months, which is excellent for this heavily pretreated population. And in terms of the overall response rates, it was really good with about 50% across both studies. Complete response rates were 39%, and it did not really change in patients who had prior CAR T-cell therapy. However, I do want to focus on the CRs in the relapse versus the refractory patient population. So if you have a patient who has relapsed and gone on a bispecific, the complete response rate is about 70%. On the other hand, if someone is primary refractory, those patients actually have a CR rate of 34%. So clearly there's much more work that needs to be done. In terms of CRS and ICANS, I can say that the grade 3 or higher toxicity is way less as compared to CAR T-cell therapy, ICANS being almost negligible in bispecific T-cell engagers. So with respect to that, in terms of the pivotal study, which made glofitamab FDA approved, we now have long-term follow-up data. And it was important to really see, because this is fixed limited, fixed duration therapy. We wanted to see if after patients finish 12 cycles of therapy, if they continue to maintain their remission or not. And the primary endpoint was complete response rate by IRC. In terms of the median age, we alluded to it was about 66, but there was a nanogenarian who actually did get glofitamab on this study. And at this point, in terms of follow-up, there were no new safety signals that were identified. In terms of the median time on study now for these patients, it's about 32 months. And with regards to complete response rates, about robust 37 to 40%, irrespective of prior CAR or no CAR administration. I think we are beginning to enter clinical trials where we are looking at responses and median duration of response in complete responders. So you will see a lot of that in subsequent abstracts. And in terms of the duration of complete response, about 55% of patients had a remarkable duration of complete response. And clearly, if you achieve a complete remission versus a partial remission, if you have the former, then your progression-free survival is excellent. So in terms of just focusing around complete responders, at the end of glofitamab treatment, the 18-month PFS for these patients is 67%. This is a highly pretreated population, and these rates are truly remarkable. Now, not everybody could get glofitamab, epcoritamab, not everybody can get CAR-T. So we really have to think through certain strategies where patients are not able to finagle caregivers, patients are not able to come from out of town. So maybe targeting these patients with a bispecific T-cell engager that's not as toxic or that's not as onerous when we initially get started. Because I will say with glofitamab or with epcoritamab, we do experience cytokine release syndrome for the first month, slowly trailing into the second month and then almost gone third month and onwards. So what we have done with the community partners is we typically get their patients here, treat them for the first 2 cycles, and then get them back to the community physicians. Now, this is a combination that's hoping to mitigate that. Mosunetuzumab is currently approved in follicular lymphoma, and it synergistically works very well with polatuzumab. Polatuzumab is an antibody drug conjugate that treats CD79B. And POLA has actually shown to have great responses in relapse refractory large B-cell lymphoma, but with its movement into the frontline setting, I don't quite know the future of this combination, but for those patients who still continue to get R-CHOP, I think this is an abstract that definitely held my attention. So mosunetuzumab plus polatuzumab basically was tested in relapse refractory large B-cell lymphoma patients. The median line of treatment was 2. About 18% of patients had high-grade B-cell lymphoma, 35% had prior CAR-T, 57% of patients had primary refractory disease. And in terms of the best response rates, you can see the time to complete remission was 2.5 months, which was excellent. Overall response rate in the 60s with a 50% complete response rate. And the primary efficacy endpoint of best overall response by RSC was actually met. In patients who received prior CAR T-cell therapy, the complete response rate was similar. And as you can see, the median duration of patients who ended up in a complete remission was actually not reached at this follow-up. In terms of the median PFS, it was 11.4 months, the median overall survival about 2 years. And in terms of safety, just want to underscore that with regards to cytokine release syndrome, grade 3 or higher was 3%. With ICANS, grade 3 or higher was only 2%. So it's quite different from what we see with the other bispecific T-cell engagers. Of course, polatuzumab is an MMAE-based antibody drug conjugate. So we do expect patients to develop neutropenia, neuropathy. So if you do have baseline grade 2 or higher neuropathy, these patients were actually not included on the study. We did enroll these patients on a trial here, and I will say that there was remarkable response for our patients who had failed CAR T-cell therapy with not just large B-cell lymphoma, but also this combination is being investigated in mantle cell lymphoma. Dr. Michael Wong actually presented that data, and we have seen most of our patients who got this combination on a study here also enjoyed the long-term remission with MOS and POLA. So clearly the area of debate in the field is, how do we choose CAR T-cell therapy, CD20 bispecific T-cell engagers? So at this point in time, axi-cell, liso-cell, tiso-cell is approved in the third-line large B-cell lymphoma setting. Axi-cell, liso-cell, as you know, based on the ZUMA-7 and TRANSFORM study, are approved in the early high-risk second-line relapse refractory large B-cell lymphoma study. And then liso-cell was approved based on the pilot study for patients who are transplant ineligible in the second-line setting. And then we have bispecific antibodies that have also made a mark in the third line setting. So the question is, how do we choose what's better than what? And Dr. Major and I were actually invited to write and deliver a talk on bispecific versus CAR at last year's ASH. And I think my takeaway in terms of whether I do CARs first or bispecifics first, I will say that my choice is CARs first. And that's primarily around the fact that CARs are single infusion, it's one and done. The response is technically irrespective of target. So people who have CD19 negative can also respond to CAR and has been shown in pivotal studies. That may not be true in bispecific T-cell engagers. There's established CNS efficacy with CAR T-cell therapy. We just don't know if CNS efficacy is there with bispecifics because those patients were not enrolled and basically ineligible for those studies. We have prospective data. All of these bispecific T-cell engagers had about 1/3 of patients who received prior CAR, and we do know that their responses are very similar to patients who received no CAR prior. So I have a line of agent that I can actually be keeping as my plan B if CARs don't work. But CARs have their issues. There's a need for lymphodepleting chemo, specialized accredited centers, clearly substantial upfront commitment, insurance authorization, manufacturing time, bridging therapy, and a higher risk of neurotoxicity. But for me, what really seals the deal here, where I say that CARs before bispecifics, is the curative potential that has been established in the third-line setting with CAR T-cell therapy. We can cure roughly 40% of patients who would have otherwise succumbed to their disease with the follow-up data that we now have with ZUMA-1 as well as Transcend. And it looks remarkable in terms of the third-line patients. About 40% can be cured. We can certainly do better. We just don't have that data with bispecifics yet. And if I was to keenly look at the GLOFI curves, I would say 57% of patients still maintaining in a complete remission. Those complete responders are still handful. So I think I'd await more data, but for now, my practice would be to offer CARs prior to bispecific T-cell engagers. But I think this debate is really going to be quite short-lived because both of these constructs are going to be moved into earlier lines of treatment. So for example, this was what we call the ZUMA-12 study, where axi-cell was actually used in the frontline setting. But basically, these are high-risk large B-cell lymphoma patients with double hit, triple hit gene rearrangements, or if they have an IPI of 3 or over. And then if their interim PET is either a Deauville 4 or higher, then you know that these patients don't do as well. And these were the ones that went on to getting axi-cell. Primary endpoint of this clinical study was complete response. A total of 37 evaluable patients at a median follow-up of 41 months had an overall response rate of 92% with a complete response of 86%. The 3-year EFS for these patients was 73%. It obviously came at the cost of grade 3 or higher ICANS of 23%, but overall, this was a very well-tolerated regimen. The median duration of response, event-free survival, progression-free survival at 40.9 months follow-up is not reached. 5 out of 8 deaths were due to progression. The others were because of COVID-19. And then GLOFI doesn't go behind, so bispecific T-cell engagers are also making their foray into frontline treatment. The advantage of bispecifics is the fact that they can actually be combined with R-CHOP. So there's a similar study with EPCO, but what was presented by Lorenzo Falci and colleagues was glofitamab plus R-CHOP as frontline setting in patients with untreated DLBCL after they assess ctDNA prior to interim PET and after cycle 2 day 1. After cycle 2 day 1, if ctDNA, which was measured by gene sequencing based on the Avenio oncology assay, if there was less than a 2-fold reduction in the ctDNA, then these patients were eligible to add glofitamab. And then glofitamab after 6 cycles was continued for a total of 10. And I will say that of the 29 patients, of the 144 patients that got screened, 29 met this high-risk criteria. The median age was 66. The short follow-up clearly mars a lot of things we can make out of this study. But I think it's important to state that the end of treatment complete response rate was 85%. And in terms of safety, absolutely manageable. But it does come at the cost of infections, which was about 40%. I will say that there are 2 ongoing studies that might displace standard of care in the next 5 years. There's ZUMA-23, which basically compares phase 3 study of axi-cell versus standard of care in high-risk untreated large B-cell lymphoma patients. And then there is the SKYGLO study, which we will be participating in, which is GLOFI plus R-CHIP versus our Trippola in untreated large B-cell lymphoma patients with an IPI of 2 or over. So we're very kicked that we will be opening the SkyGlow study for our patients who do have a high-risk IPI with newly diagnosed large B-cell lymphoma. So let's switch gears. Let's move on to follicular lymphoma. We do know that despite the fact that follicular is an indolent lymphoma, about 10% of patients at 10 years will have death because of lymphoma. And we do know that the overall survival gets compromised with every subsequent line of treatment. We also know of this new marker, which is POD24, which basically means progression of disease within 24 months of receiving frontline chemoimmunotherapy. If patients experience progression within 2 years of receiving frontline chemo, then their 5-year overall survival is less than 50%, 70% of which have actually experienced transformation. The remaining, the overall survival is actually equivalent to age-matched controls. So clearly, we need to do better. And in the relapse refractory setting, we do have a luxury of 3 constructs that have been FDA approved. Based on the ZUMA-5 study, we have Axi-cel. Based on the Elara study, we have Tisacel and mosunetuzumab, which is all approved in the third-line space in relapse refractory follicular lymphoma. So it's really important to understand what's the long-term follow-up with all of these 3 constructs so we can really choose the best strategy for our patients. And I will say cross-comparison is sacrilege within our practice, but I think it helps you gauge where we are today. So we do have a published manuscript by Dr. Nilapu and colleagues of the ZUMA-5 study, 127 patients enrolled, experiencing 79% complete response rate. Clearly, this comes at the cost of CRS and ICANS, but the median duration of response is 40 months, median PFS of 40 months, median overall survival not reached, and the 3-year PFS of 54%. Of course, POD24, 70 patients made up for POD24, and the median PFS was slightly less, but still quite good at 40 months versus not reached in the remainder of the population. So what happened at ASH? We had 2 follow-up studies. We had the Elara study, the Tisacel study, which was presented by Dr. Schuster. This was the 3-year follow-up of the Tisacel study, 97 patients enrolled, complete response rate of 70%. But notably, CRS and ICANS absolutely manageable. In terms of median duration of response, it's not reached, median PFS 37 months. And in terms of POD24, the median PFS 30 months versus not reached. So quite comparable. I will say that TMTV, which is a PET-based parameter, prior bendamustine use, has all been attributed to negatively impact outcomes with CAR T-cell therapy. So mosunetuzumab, we do have now a 3-year follow-up. Dr. Schuster also presented this study of 90 patients. Complete response rate is quite comparable, but if you look at it numerically, slightly lower at 60%. CRS ICANS, very manageable. ICANS almost not there. In fact, headaches and peripheral neuropathy, if you look at the package insert, is what is noted in the neurological toxicity. So you don't really get the classic ICANS with CD20 bites. With median duration of response of 35.9 months, again, median duration of complete responders, because this is time-limited treatment, was not reached. But the median PFS is slightly short at 24 months. If you look at the median overall survival, it's 82% because we have many other options that are available. So again, what do I choose? I clearly have a preference for CARs over BiTEs, but I think this kind of consolidates me to say I probably would go with CARs. And between the 2 CARs, it depends on insurance authorization, et cetera. But if this is a true follicular, I think Tisacel is a really good strategy based on the manageable side effect profile and very equivalent efficacy in highly pretreated follicular lymphoma patients. So moving forward, this was the new kid on the block, Transcend, which was exploring Lyso-cel in the second-line therapy setting. The Transcend follicular lymphoma study is a large study. We participated in it. We had patients with relapsed refractory follicular lymphoma in the 4th-line, 3rd-line, 2nd-line cohort. But this data was basically in the 2nd-line cohort, so just focusing on POD24 or patients who relapsed with Guelph criteria that needed therapy. So they got Lyso-cel, a total of 23 patients in the 2nd-line setting, 101 in the 3rd-line setting. And the net is that the complete response rate, where the 2nd-line or 3rd-line was upwards of 90%, highest that we have seen amongst all the other CAR constructs, and at a side effect profile that is absolutely manageable. So CRS, there were no grade 3 or grade 5 CRS. ICANS, there was just 4% grade 3, no grade 4, grade 5 ICANS. After a median follow-up of 17.8 months, the median PFS was not reached, the median OS was not reached, and you can see the median duration of response, whether it's second line or third line, was not reached. So I do believe that this is an excellent construct. But clearly bispecifics cannot be behind. So what do we have with regards to mosunetuzumab? So mosunetuzumab is an exceptionally well-tolerated agent in relapsed refractory follicular lymphoma. And this is a study that was presented by Lorenzo Falchi in the frontline therapy for patients with high tumor burden follicular lymphoma. This was only single agent mosun, 26 efficacy evaluable patients, time limited. Overall response rate remarkable at 96%, CR of 81%. Median follow-up is very short, but at a median follow-up of 6 months, 2 patients of the 26 have relapsed, one with transform lymphoma, one with a CD20 negative lymphoma. So I don't know what this really means for the future of treatment for B-cell lymphomas with Mosun, because if you lose CD20, is it a good thing? Is it a bad thing? Do you make patients have more aggressive phenotypes? We don't quite know. So long-term data is awaited. But in terms of the practice impact of these abstracts for me, I will say that both CD19 CARs and bispecifics are efficacious in relapsed refractory follicular lymphoma. I am more partial towards CAR only because of the higher CR rate, as well as better POD24 data. With Mosun, we don't have POD24 data yet. I think it's going to be presented at EHA. Liso-cel has so far shown to have the highest response rates. So if these end up being durable, then obviously we pivot based on FDA approval, which is awaited. And then subsequently, these are constructs that are obviously going to be tested in the frontline setting. So this is a study that we will very soon be participating in. It's a SWOG study in low tumor burden follicular lymphoma. We obviously have the idea of watch and wait, but clearly not a lot of patients are comfortable with watch and wait. And clearly there is this hope that could we cure patients with less toxic treatments. And this is a study that will randomize low tumor burden follicular lymphoma patients to either getting rituximab in its standard dosing or mosunetuzumab. And I'm eagerly looking forward to opening this study for our patients. Let's pivot to mantle cell lymphoma. So mantle cell lymphoma is clearly heterogeneous. There is no cure yet that we know of, but thankfully the outcomes have improved with a plethora of agents that have been approved. But we do know that after relapse post-covalent BTK inhibitors, which is acalabrutinib as well as zanubrutinib. I can no longer talk about ibrutinib because there has been voluntary withdrawal of the drug for mantle cell lymphoma. But as you can see, when patients relapse with mantle cell lymphoma, after having experienced BTK inhibition with covalent BTK inhibitors, the median overall survival is only 4 months. And then this is a very different beast within mantle cell lymphoma. TP53 mutation positive mantle cell lymphomas do not do good. And they have extremely dismal outcomes in the frontline setting as well as in the relapse setting. And clearly we are moving away from chemotherapy, but the Nordic study basically says that do not auto-transplant patients with TP53 mutation because their outcomes are really poor with auto. So why give them the toxicity? We need to start thinking out of the box. So in terms of what we have with regards to follow-ups and abstracts that were presented in relapsed refractory mantle cell lymphoma, we have pirtobrutinib. So pirtobrutinib is a reversible non-covalent BTK inhibitor, and this is the pivotal Bruin study. Median lines of treatment was 3. 20% had TP53, blastoids, 9% had prior CAR, 152 patients had received prior covalent BTK inhibition. Pirtobrutinib is an exceptionally well-tolerated pill. It's once a day. Overall response rate is 50%, complete response rate of 24%. And you can take a look at the median PFS at a follow-up of 16 months, median PFS of 6 months, median duration of response, 21 months, median overall survival, 23.5 months. But to dig deeper into this study a little bit, if you take a look at the forest plots, I will say the pirtobrutinib works really well for most subtypes, barring blastoids, pleomorphic, TP53, and patients who receive prior CAR. So I think I just want to highlight that if somebody is responding to PERTO, but they do harbor these high-risk mutation profiles, it's really important to start thinking ahead and plan a strategy B for these patients, especially TP53 status, because the median PFS, if you have a mutated TP53 on pirtobrutinib, is actually only 4 months. But like I said, exceptionally well tolerated. A lot of patients ask me if I'm giving them a sugar pill, which I'm not. Only 3% of patients discontinue treatment. So it's an exceptional drug. But the way I use PERTO in the high-risk mantle cell lymphoma setting is I really use it as a bridge to something else. So I'm looking for clinical trials. I'm looking to get them to CARs. I'm looking to get them into better cellular therapy products. We actually have a bicistronic CD19/22 mantle cell lymphoma study that is open and enrolling patients exactly like this. This is the phase 3 Simpatico study that made it to the late-breaking abstract. I don't quite know how to put it in clinical context, though, but it made it to the LB82 presented by Dr. Michael Wong. So this is basically a study in relapsed mantle cell lymphoma, randomizing them to either ibrutinib plus venetoclax. And at the 2-year mark, they discontinue venetoclax and then just be on ibrutinib until progression. The other arm gets standard of care, which is ibrutinib. And the net is that these high-risk patients, 30% were TP53, median age was 68. The median PFS was substantially, significantly improved in patients who got the doublet versus ibrutinib alone. Also, the complete response rate was higher. The median overall survival is not statistically significant, but numerically higher in the doublet. As you can see, in terms of grade 3 or higher side effects, the doublet will cause more side effects, more cytopenias. There were more COVID-19 related AEs, but no increased COVID-19 related deaths. Pneumonia is numerically higher in the doublet. No clinical TLS was seen, so that's really good. But overall, I think I don't quite know where to put this clinical trial into clinical context because of the voluntary withdrawal of the ibrutinib in the US for mantle cell lymphoma. Extrapolation with ACAL plus venetoclax or ZANU plus venetoclax, I'm not quite certain, especially because there is not an overall survival improvement yet. This was a really unique study, and I love this study presented by the delightful Anita Kumar from Memorial Sloan Kettering. But it was also really using a very creative way to tackling TP53 mutation mantle cell lymphoma patients in the frontline setting. This was called the Bowen study, which was an MRD guided study, zanubrutinib followed by venetoclax, obinutuzumab for a total of 24 months. And they were looking at complete response rates and detection of MRD at the end of 24 cycles to suggest if patients could go off of study. Small study, 25 patients, but the primary endpoint was a PFS of 2 years, median follow-up of 24 months, exceptionally well tolerated outside of grade 3 neutropenia, which was handled by GCSF. The results are spectacular. Complete response rate of 88% in this highly highly high-risk subset of untreated mantle cell lymphomas. So far, 5 patients have experienced progression. 4 deaths that happened on the study was in response and not due to progression. 11 patients have so far completed treatment, and 10 could have MRD data available. 8 out of 10 had undetectable MRD, so they have stopped. And you can see that the median PFS is pretty good. So in terms of practice impact from the standpoint of mantle cell lymphoma, I would say pirtobrutinib is promising, but probably not that promising and durable in high-risk subtypes of mantle, but it could certainly be used as a bridge to something. Venetoclax, ibrutinib superior to ibrutinib, but not quite sure how to put it into clinical context here. And I do believe TP53 mutation mantle cell lymphoma patients are an ongoing challenge. So it's really my plea to make sure that all the clinicians like us, we must check for TP53 mutation as well as aberration. So not just FISH, but also gene sequencing so that we can route our patients accordingly. And then to really close up on the last 5 abstracts, we're going to talk about some pivotal data from the CLL sessions. This is the 6-year follow-up of the Elevate-TN study. We participated in this study. We have a lot of patients still doing really well. And the net is that this study was study of around 530 patients randomized to acalabrutinib plus obinutuzumab versus acalabrutinib versus obinutuzumab plus chlorambucil. So clearly the straw man comparison, but that's what we had 6 years ago. And overall, I can say that in terms of median PFS, ACAL did much better than obinutuzumab plus chlorambucil. In fact, there was an overall survival difference that has emerged between the ACAL arms and chlorambucil arm, but that's again no surprise. However, what is interesting to see is that at the 6-year follow-up, if you look at the median PFS for patients who received obinutuzumab, it was 78% versus for the ACAL arm at 62%. The overall survival still remains fine. So in terms of, what does this really mean for us? Would I use it in my clinical practice? I have offered it to patients, but honestly, BTK inhibition versus BCL2 is a little more cumbersome, although time limited. BTK is supposed to be very seamless. So when I bring them in for infusions, I'm basically making them get stuck to a pole. And at the risk of saying that there is no overall survival improvement yet, I'm still offering only BTK inhibition up front, but I think things are changing very rapidly. With regards to frontline studies, we clearly have venetoclax combinations. We do have venetoclax plus Gazyva or obinutuzumab based on the CLL-14 study, which is a standard of care now for 12 months. This was the CLL-13 study for frontline patients. No TP53 patients were allowed, but basically randomizing them to chemoimmunotherapy, rituximab plus venetoclax, obinutuzumab venetoclax, obinutuzumab ibrutinib venetoclax. There was no venetoclax ibrutinib arm. So the primary endpoint was progression-free survival. Overall, the median observation time on this study was 50 months. And you can see that in terms of the PFS curves, Gazyva ibrutinib venetoclax was superior to chemoimmunotherapy. Anything with obinutuzumab is better than rituximab. And in terms of this, I think this is very intriguing to me. In patients who had unmutated IGHV, they tended to do better with a triplet than with obinutuzumab venetoclax. With mutated IGHV, I think this is the takeaway for me is that venetoclax plus obinutuzumab is just enough. And then still there is no overall survival difference. If you give a triplet, there are more toxicities with regards to cytopenias, obviously. But it's very intriguing to see that the doublet or the triplet is emerging to be the theme for patients who have unmutated IGHV. So whether you look at the Captivate data with ibrutinib venetoclax, if you look at the unmutated patient population, they actually tend to do much better with the doublets than the mutated. So my takeaway is for mutated CLLs, I typically do the doublets, which is the CLL-14. For the unmutated, I think it's an ongoing discussion about BTK versus ibrutinib plus venetoclax, although it's not technically FDA approved. This is the Alpine study, which was a phase 3 study that looked at zanubrutinib versus ibrutinib. The net is that the previous follow-up showed a progression-free survival difference. This is the only BTK that has actually shown a PFS difference as compared to ibrutinib, because the previous study with acalabrutinib versus ibrutinib did not show a PFS difference. In terms of toxicity profile, there is hypertension with zanubrutinib, but in terms of atrial fibrillation, way less AFib as we expect as compared to ibrutinib. So in terms of, how do I assess zanubrutinib and acalabrutinib? I don't know. Zanubrutinib seems to be better than ibrutinib. Is it because people who had ibrutinib on this study discontinued ibrutinib a lot more? This was also the relapse refractory study, so I don't know how to incorporate it into frontline data sets, but I don't quite believe that the mathematics of Zanu is better than ibrutinib, and if acal is equivalent to ibrutinib, then Zanu is better than ibrutinib or acal is true. I think for me, second generation BTK inhibitors are quite efficacious and similar, and I basically approach my patients with both of them. In terms of what's new in CLL, as you know, pirtobrutinib, which is the non-covalent BTK inhibitor, was recently approved by the FDA for patients who have experienced covalent BTK inhibition and BCL2 inhibition. This was the 30-month follow-up, and it basically stratifies patients based on if they were BCL2 naive versus they were BCL2 exposed. the net is that if you're BCL2 exposed, the benefit you get from Perto is not as high. The median PFS is 15.9 months versus if you're BCL2 naive, the benefit is 23 months. So I think this sets into motion the discussion about how do we sequence our agents? Because if we get the best bang for the buck with Perto before they get exposed to venetoclax, is that the space for Perto? Or should we use Perto after exposure to two BCL2 and BTK, which is the FDA approved verdict? But I think clinical trials are going to certainly throw more light into how this is going to evolve. But even in this heavily pretreated setting, Perto was exceptionally well tolerated. So I would say the practice impact for me with the Elevate-TN study is that adding obinutuzumab is valid, reasonable to deepen the responses. But remember, that does not stand true for patients who have TP53 mutation. So if they have the mutation, acalabrutinib plus obinutuzumab did not show higher PFS compared to acal alone. With regards to CLL13 study, I think what it told me was obinutuzumab is better than rituximab. Also in the unmutated IGHV setting, maybe I need to think something else for them in terms of maybe a triplet or a doublet strategy and more to evolve over there. All-point study, I feel like, yes, Zanu is exceptional, great in terms of this efficacy as compared to ibrutinib. I cannot make much of Zanu versus acal. And the Bruin study, I think great response rates, but a very modest PFS if your patients have been venetoclax exposed. So starting to think about plan Bs is very crucial. And last but not the least, I would take 2 more minutes of your time to look at some of the Richter's transformation data. Finally, we are beginning to see some improvement here. So this is the historical progression-free survival and overall survival data in patients who experience Richter's, median PFS of 4 months, median overall survival of less than 6 months. So clearly a lot of scope to improve. There were several abstracts. There is epcoritamab that has shown excellent responses. Glofitamab is being explored in Richter's transformation. There is, of course, the combination of PD-1 inhibition plus BTK inhibition that has shown responses. But the 2 abstracts that I picked was pirtobrutinib in Richter's, also because these patients are very frail. So by the time they get to a relapse Richter stage, they are either cytopenic or their performance status is quite challenged. And I feel like a drug like Perto works exceptionally well because the side effect profile is so lovely. In terms of median age, 26 to 95 was the range. Median lines of treatment was 2, whether patients had CLL or Richter's. And you can see the waterfall plot. The median time to response was less than 2 months. And in terms of the median follow-up at the 1-year mark, the median PFS is 3.6. I don't know if this is a function of a shorter follow-up, but the median overall survival is 12 months. And I think this is something that is clearly important to take note. Obviously, this means that Perto can be used in combination with something. So I look forward to multiple Perto studies exploring more in Richter's. And this was a multi-center mammoth effort by Adam Kitai from Ohio State University, looking at a multi-center retrospective study utilizing CD19 CARs, which were FDA approved in patients with Richter's. The median overall survival was 8 months. The median PFS was 5 months. In complete responders, 46%, the median duration of complete responders was actually more than 2 years. And the median duration of partial responses was 2 months. So I do believe that, you know, if in the world of Richter's, you have the opportunity to get a patient in complete response, and if they are young and fit, that's the time to really talk about an allo. Outside of that, I think clinical trials is the only way to proceed. For example, we have a ROAR1 study that's led by Dr. Stephen Baird that enrolls Richter's transformation patients. And I am just, you know, very kicked looking at all of this data that's beginning to emerge. But with that, with such a promising ASH for B-cell and T-cell lymphomas, I hope this was not too fast, but I tried to cover the most I could. And thank you so much for your patient listening.
That was great. Thanks, Manali. Yeah, excellent review. And so we have any questions from the audience? Yes. Not sure if this is working. Can you guys, is this working? Can people hear me? We were just talking loud.
Hello. Yeah, I have a question. I did not hear anything about the CD47-based therapy. Is that mantle cell lymphoma CD47 positive?
So I think some of these, so the CD47 or the don't eat me signal has been explored in patients with diffuse large B-cell lymphoma. And I think we have the magrolimab data, but I don't believe that currently it is being explored in mantle cell, or I don't know of. But yes, I think that seems to be a promising approach based on some of the data that we saw in the New England Journal of Medicine article.
Thank you.
Any other questions? Yes, Dan.
Just have a logistical question. When you mentioned the P53 status for mantle cell is influencing your clinical decisions, is that something you're able to sequence, or community doctors are able to sequence?
So that's an excellent question. Clearly FISH is standard of care. So we do get the data on deletion 17, whether they have it or not. But we don't get the data on TP53 mutation, which is a gene sequencing study. So, that's just one company I use a lot and tell my community partners to do, which is NeoGenomics, because the turnaround from them for TP53 mutation is quite rapid. So you know very quickly whether the patient harbors it or not. And I will emphasize that between deletion 17 and TP53, TP53 mutation, TP53 mutation is a worse actor. So, sometimes we just look at the FISH and say the patient doesn't have TP53 aberration, but completely forget to check the TP53 mutation status. So I think that has to be built in within our guidelines.
And Manali, I have a question. So as a non-lymphoma person, and you may have commented on this, and I may have gone right over my head, but so for the patients with mantle cell lymphoma and with ibrutinib being withdrawn, I guess, could you comment on like the role for like an agent like pirtobrutinib? Like why would an agent like that potentially be something?
No, I think this is all an evolving field right now, but I think our biggest challenge right now is to interpret some of the really good data that came out of last year's ASH, which is the Triangle study for mantle cell lymphoma. This data was exploring patients with chemo plus ibrutinib without transplant versus chemo plus transplant versus chemo, ibrutinib plus transplant. And the net was that transplant is no longer required if you actually incorporate ibrutinib upfront and for 2 years after completion of chemo. But with the withdrawal of ibrutinib in the US, we don't know how to extrapolate. So we have our own programmatic approach within our program where all of us have decided that for our patients who have a newly diagnosed mantle cell lymphoma, and if they are not really into auto transplants, I doubt anybody is at this point, we typically give them RD hacks, which is a Lima study induction chemo. It spares them the cisplatin and replaces it with oxali. We give it for about 4 cycles, and then subsequently we start them on either ACAL or ZANU for 2 years. So we do an extrapolation of Triangle, but with the idea and acknowledgement that we don't know if we will be able to replicate the same results. This has just gone off the floor as of 2 months ago. So maybe next year would be able to tell you a little more in terms of how our patients are faring. For our TP53 mutation patients, we really try and incorporate BTK inhibition upfront. So for our older ones, we typically do the indolent, the strategy that was done by the Europeans, which is rituximab plus a BTK inhibitor. For the blastoids, etc., sometimes they just need that chemo to stabilize them. So then we still use the RD hacks followed by the BTK for 2 years.
Thanks again. It's excellent review.
All right. Thank you so much.
And so with that, we're just about